This feels a bit old Top Gear perched on the bench here. Right, know your stretchers. So this is a long board. This used to be referred to as a spinal board, but we don't use these for spinal immobilization anymore because they cause pressure injuries, because they're very hard and they don't conform to people's spines. So these are really bad for long-term care. So we use these as an extrication board because they're very low friction. You can slide people out on them. So we use these to get people out of cars, but we don't transport them on these type of stretchers anymore. These are the head blocks for immobilizing, but you can use these with the scoop stretcher. We'll have a look at all these in a minute. But the scoop stretcher breaks in half and conforms to the spine with this space here, which means that the incidence of pressure injuries is significantly reduced, although you've got a relatively small time scale as well to get people where they need to go on this without suffering spinal injuries. This is a drag stretcher, which is a fantastic piece of equipment that we use for remote medicine. Weighs 2 or 3 kilos, but it's far superior to any kind of improvised stretcher that you might try and use to get people off a mountain. I'm back in the workshop because it's too windy outside really for the microphone to pick up properly. This is the first board that I was looking at, which we used to call the spinal board, but we're very keen to try and move away from that terminology these days and call it an extrication board. In years gone by, and we're not talking a huge number, if you had a suspected spinal injury following, say, a road traffic collision, you'd been in a car accident, this is what you would have been put on, and you would have been immobilized on this. The issue with this device is that it's made from really hard plastic. So if you're unconscious and you're unable to move, you've got a really high risk of sustaining a pressure injury, so a pressure sore. Less so, I suppose, if you're awake, but they are excruciatingly painful within about 5 or 10 minutes of being in one of these, especially if you're immobilized with these head blocks and you have a collar on to immobilize your neck further and then you're strapped to it. It is incredibly painful, and I've not been strapped in one of these in anger, but I have certainly used one in testing and familiarization, and I can attest to the fact that in 5 or 10 minutes you do feel very uncomfortable. This is the Longboard cervical spine immobilization system. There's 2 of these big foam blocks that go either side of the patient's head. These have reciprocating Velcro, which means they can be moved in and out depending on the width of the patient's head, and then they apply like that. So they're held very securely on the board. One of these straps then goes around the patient's chin, and then one of these goes across the forehead. Now you can replicate very much the same effect on the scoop stretcher by putting the blocks in the other way around and then taping the patient's chin with tape and the patient's forehead with tape. There's a bit of a knack to doing that, but the point is you can immobilize their spine pretty well. So this is the Laerdal stiff neck adult cervical collar. And the thing to remember with all semi-rigid collars is that this does not provide in and of itself adequate cervical spine immobilization. It needs to be used in conjunction with something else, like the head blocks or with somebody else holding the head. You'll see once these are on that people actually have quite a degree of freedom of movement about how they can move their heads when they're wearing it. I'm not going to go into how to fit them. There are better product videos online that you can look at. The process is different for each product, so it would be fairly pointless. So that's me now wearing the attractive Laerdal stiff neck collar, but really to demonstrate that actually I've got quite a degree of head movement even though I'm wearing this. Now, if a patient's unconscious, if a patient's unconscious, they should certainly have one of these applied because they can't protect their own neck. If you have a patient that's combative though, so if I was intoxicated or I had a head injury and I was a little bit fighty, you may actually do more damage by putting one of these on. So if you have a combative patient who's conscious and wrestling, then actually this may be counterproductive, and that's in line with guidance. These are all the things that you need to consider. I would go back to first principles though. If you are in doubt and a patient has a cervical spine injury, then yes, it probably is the advised thing to use one of these. This is the scoop stretcher, and it breaks in half, and because of this scooped out area, the spine conforms to this a lot better, and it can be used in the same way as the longboard with these blocks to immobilize the head, but they get turned round the other way, they get inverted that way. And then we use tape to secure the head at the top, because there's not the same Velcro strapping system on these, and that's fine, and that's approved for practice. Again, you can use these with or without a collar, but these are by far and away the preferred option for spine. If you have a patient that you need to immobilize and transport, this would be the thing to transport them on. Saying that, the recommendation is that scoop stretcher should not be a metal one because of its thermal conductive properties. So if it's very cold, this is going to make you colder, and if it's very hot, you may get a thermal injury, you may get a burn from this, especially if you're somewhere particularly sandy and exotic where the ambient temperature is 40 or 50 degrees, which is certainly not unheard of. So ideally these should be the plastic version rather than the metal ones. Saying that, the metal ones are incredibly robust and don't tend to break that easily. So the scoop stretchers break apart, as we talked about, and they've all got a clip system. This one has one here, although there are slight variations across models. But you press that one in and then pull the stretcher apart. To clip it back together, you line it up and clip it in. If you've got a weight on these, sometimes they don't clip apart terribly well. So if you're offloading your casualty in an emergency department after you've brought them in by ambulance, these can be a bit sticky. Sometimes just leaning on one corner and then pressing the clip allows it to slide apart a little more easily. And the reverse is also true when you've loaded your casualty. To get it to clip in, if it's not quite lining up, just applying a little bit of weight on one corner and then locking it together can make the difference. The scoop stretcher is adjustable to the height of the casualty, and indeed should be measured so that the feet are down this end and the head is up the other end. There are two clips here that slide in and out, and you push and pull the length of the stretcher to the correct length of the casualty. The pro tip here is to push these clips down before you try and find the reciprocating holes, and then pull the stretcher to the correct length so the clips then go into the holes. If you're trying to line up the clips with the holes as you turn them, it becomes an exercise in frustration. And that's the scoop stretcher broken down in half. The idea is that you slide one blade under the patient, you minimally roll them up to certainly not to more than 15 degrees, slide this under the patient, go around the other side, put the other blade in, roll the patient again to scoop this in, hence the name of the stretcher, and then you clip one end together, and then the other. And this is my favourite, probably because it's quite gadgety. This is the drag stretcher. Weighs about 3 kilos. I shouldn't have grunted when I picked that up. Weighs about 3 kilos, so it's certainly very portable. Comes in this roll bag type bag. It's about the same size as a sleeping mat. This is the drag stretcher laid out. It's difficult to show inside because the space is so limited, but it has a patient side, which is this rough side with all the straps on it for securing your casualty. And it's great because these are all integrated with the other devices like the spinal board and the scoop stretcher. You have to carry separate straps. They inevitably fall off and they go missing. These, they're attached so they can't go missing. So rough side, and a low friction drag side. So it's called a drag stretcher because up here is a long strap that attaches to the head of the stretcher. And the idea is that rather than carry people, you can pull them with these long straps at the top. I've done it and it works fine. It does tend to degrade the quality of the stretcher, and they can break quite easily, but it works relatively well. Alternatively, you've got carry straps, 6 of them, so you can get a 6-man team around to carry the casualty out. 6 people on a stretcher means that people start tripping over their feet though. You can, of course, improvise a stretcher, and this is a storm shelter, which is a large piece of fabric, and you can, if push comes to shove, put somebody in this, tie knots in the corner and pull them. This is an old desert camouflage British Army shelter sheet, and you can see it's got handles on it here, and the idea is that you would fold this in half, lie your casualty along, and then a group of people would pick up these handles and try and move them. The problem with solutions like this or the storm shelter is that they don't have any structure, so your casualty flops around, bits fall out, arms and legs, hopefully still attached to the patient, but they drop out the side of the stretcher, which means that they are really difficult to carry and people become fatigued. It's not great for patient handling. Bear in mind that if you have a patient who has suffered a significant degree of traumatic injury, so they've had energy imparted to them, and they have a bleed, so they maybe have a hemorrhage from a laceration or maybe a catastrophic hemorrhage in the terms of amputation, that these patients are going to start to clot, and it's that clotting process that's going to save their lives. If you start rough handling patients by dragging them across rough ground on something like this, you increase the chance of disrupting the clot, which means that they suffer a greater chance of significant blood loss, which decreases their chance of survivability. That's why the drag stretcher that we looked at is much better for a lightweight carrying device, but ideally, and if you've got one, then the scoop stretcher is the way to go. In terms of trying to carry anybody on a drag stretcher or even a scoop stretcher across uneven terrain, it is exhausting. If you've got a 6-man team, there are 6 straps on this, people's feet get tangled up with each other. You certainly need to allocate somebody at the front to coordinate what people are doing. Remember, torsos are heavier than legs, so it's a good idea every 100 or 200 meters to stop and to swap front to back. Don't underestimate just how tired people become. If you've got a large party and you're trying to evacuate them, try and take some of the weight out of people's backpacks that are carrying the stretchers and distribute it amongst those people who are not. You may have stronger people in the group who may be able to endure carrying a stretcher for longer than others, and these are all the things you have to take into account. It's very difficult, I think, when you're an expedition leader or you have responsibility for people and environment like that and you're trying to get them to safety, to not get involved. You want to get hands on a stretcher and show like you're getting stuck in to help move the casualty. But that's the wrong thing to do. You need to have your head on the overall plan. You need to be talking to people about terrain that's coming up and guiding them. You need to be thinking about what are your evacuation routes, where are you going to rendezvous with other medical resources. So you need to step back and take an overall view. But don't underestimate how hard that is to do.